Good morning, good afternoon, and good evening. Welcome to all. Thank you so much for being part of our session today. We are just getting started. Welcome to the CUGH satellite session, Opportunities for Health Profession Education Institutions to Strengthen the Health Workforce, a review of practical approaches and tools. Please, as you are settling in, share in the chat your name, your location, affiliation, and why health workers matter to you. We will start with some introductions, but before we do, let me just get myself around here. There we go. Before we start, we would like to acknowledge the traditional ancestral unceded territory of the Piscataway, Pamunkey, Nantego or Nanichok, Mattaponi, Chickahominy, Monacan, and Powhatan First Nations on which we are living, learning, working, building community, and organizing today. I will pass it now to my colleague Jenny as she'll kick off the introductions for us on the presenter side.
Awesome. Thank you, Rachel. Thank you, everyone, for joining in this morning, this afternoon, wherever you may be. My name is Jenny Danjoint. I am a program manager at CUGH International with the health practice, joining you all from beautiful Maryland. Health workers matter to me because they've shown me kindness and care when I got very sick as a Peace Corps volunteer in Morocco and even different places around the world that I've been, and all the gratitude to the great nurses and doctors and people who advocated for me when I was too sick to do so myself. So very grateful for all health workers. Over back to you, Rachel.
Thanks, Jenny. My name is Rachel Dessum. I'm the HRH2030 Technical Director and the Health Practice Director at CUGH International within our Global Health Division. And health workers matter to me because they've been there for me when I've really needed them, from when I broke my neck in a car accident when I was 11 to when I was pregnant with twins. And the combination and interactions between all the health workers to help me when I was vulnerable was really meaningful. Over to you, Katie.
Hi, everyone. Welcome. I'm excited to meet you all throughout the session. So my name is Katie Gurrence. I'm the Human Resources for Health in 2030 Monitoring and Evaluation Specialist at CUGH. And I appreciate health workers, and they matter to me because many of my friends and family are health workers, and I see the care and dedication they put into ensuring that their communities are healthy, and I want to see them supported as well. So feel free to share your name, your affiliation, location, and everything in the chat, as well as how health workers matter to you. And I'll hand over to Rachel.
Thanks, Katie. So countries around the world face major health worker challenges, including supply shortages, insufficient skills mix, inequitable distribution, competency gaps, and low performance. For context, in 2015, the World Health Organization estimated a shortage of 18 million health workers by 2030. Since then, the COVID-19 pandemic is decimating, in present tense, the workforce that must be strengthened for future pandemics, health emergencies, and delivering universal health coverage. So drawing on lessons learned from the USAID-funded HRH2030 program, our session will take a human or health worker-centered approach. We'll review the health worker lifecycle, map relevant stakeholders and data sources for human resources for health, also known as HRH. We'll share examples of tools and approaches to analyze and address workforce challenges and provide case studies for building, managing, and optimizing the health workforce so that it can be more diverse, robust, resilient, and responsive. And we intend for you to enhance your ideas on the potential role of education institutions to contribute to health workforce strengthening, whether that's for pre-service education and in-service training, to address these broader systemic workforce challenges, to improve the quality and availability of health worker data, to support strategic planning and policy, and to consider health system side workforce management and performance. It's great to see all of you sharing your introducing yourselves in the chat. And please note, Jenny has also included the Google Doc, which shares our agenda and some more instructions and resources for the session. So we're going to start by looking at the health worker life cycle. We'll then go into some breakout rooms and do a brainstorming activity. And then we're going to go through 3 series of engagement. So first, reviewing the approaches and tools for optimizing the existing workforce with a case study, managing the health workforce, followed by a case study, building the future health workforce, followed by a case study. There will be some bio breaks in there as well. And then we'll close with a broader discussion, reflections, and Q&A. But please do feel free to share your questions and comments in the chat at any time. So first, about the Human Resources for Health in 2030 program, known as HRH2030. It's a global, now almost 7-year cooperative agreement funded by the United States Agency for International Development, or USAID, and the US PEPFAR program to help low and middle income countries develop the health workforce needed to prevent maternal and child deaths, support the goals of Family Planning 2020 and now 2030, control the HIV/AIDS epidemic, and protect communities from infectious diseases. HRH 2030 has worked in more than 30 countries to help build health worker competencies, skill mix, productivity, and performance, while also supporting local, regional, and national governments to strengthen their leadership and capacity to ensure an accessible, available, acceptable, and high-quality, high-performing workforce. Through these efforts, countries are better able to make progress towards their own health objectives and move forward on the path to universal health coverage. You'll note that these project objectives displayed here are aligned with the World Health Organization's 2030 Global HRH strategy. So we're all on the same foundation as we get into the session. Health and care workers are defined by the WHO as all people engaged in actions whose primary intent is to enhance health. That could include ministers of health, district-level facility managers, doctors, nurses, midwives, pharmacists, lab techs, community health workers, social workers, and many others. Let's think holistically about who are contributing and enhancing health. Health and care workers drive health systems. Without them, healthcare services could not be delivered. They are agents of positive change in their communities. They are essential actors for achieving health equity and social justice. And depending on how the health workforce is trained, distributed, and supported, it may or may not be effective at addressing the social and systemic determinants of health, including reducing inequities. In addition, wherever they are in the world, health workers deserve to be safe and protected at their jobs. They deserve fair remuneration for their work. So let us move from applauding health workers to acting for them, to better conditions and improving their systems and structures to enable their success. So now we'll look at the HRH 2030 health worker life cycle approach. Recognizing that previous health workforce frameworks tend to focus on systems at the macro level across health, education, and labor sectors, such as those developed by the WHO, we developed the health worker life cycle approach to illustrate goals for health workforce investments based on an individual or the health workforce journey through the health system. So it outlines the person-centric outcomes of policies and interventions to build, manage, and optimize human resources for health, to ensure health and care workers reach their fullest potential at key stages of their development throughout career progression, and also to fulfill their potential to the communities that they serve. So, as mentioned, we consider 3 main phases: building the workforce, managing the workforce, and optimizing the workforce. For building, this begins at secondary school graduation, proceeds to enrollment, and moves to completion of quality health professional training and education. Second, so that's the orange section of this diagram. Second, it considers the management and support for certified professionals who we hope can seek and achieve fairly remunerated, fulfilling jobs to perform well and advance their careers with opportunities for growth. That's the green manage section. And third, it highlights roles and tasks and the interactions between all practicing health workers in facilities and communities that are ideally optimized within a high-performing health system, where the services and the teams can be responsive to current health system needs and population needs and any emerging ones. Continual learning, support, and protections for all health workers and health professional students are paramount across all stages of the life cycle. So this life cycle approach allows us to envision what would be the ideal or perfect scenario of a health worker life cycle. That a motivated youth with interest in serving their communities and addressing health inequities enters and can enroll successfully in a health education program, that they can financially manage that they have access to both theoretical and practical learning, that they're able to successfully graduate with the right kinds of skills that their communities need in terms of the health services they need, that they're able to find a decent job, that they're able to stay in the health sector because they have the enabling environment, that they have the protections, as well as opportunities to keep learning, improving their skills, advancing in their careers, and ultimately interacting with all of the other health workers in the health system who are also really fulfilling their greatest potential. That's the vision, that's the goal. So today we're really going to look at some of the components and ways that we can be working towards that greater goal. So where do we begin? To help us decide and share a bit of reflection, please share in the chat, based on your experience, how long on average does it take to train a new health professional? We recognize, as we had shared, there's a broad definition for health and care workers, but if you were to estimate, on average, because as we look at investments for strengthening the health workforce, we know that there are some that might be short-term, some that may be medium-term, and some that might be longer-term investments. And of course, as we're looking across the health worker life cycle, we can recognize as contributors to health and those working in health and health education systems that all of these investments are happening at the same time, right? We're building the workforce and managing and trying to optimize all at once. Thank you so much, Sandra. I see you're sharing that for nursing, it could be 5 years or 4 years, depending on a diploma or a bachelor level. So that's many days, many months, and many weeks to invest a new health worker. So thank you, Francesca. In Côte d'Ivoire, nurses and midwives take 5 years. In Tunisia, around 4 years. Thank you for sharing all. So we recognize that there are health worker challenges and big gaps in the needs. I'm seeing 8 years for doctors. A district coordinator is 6 years. That's a long time when we're seeing big gaps and shortages in the health workforce. So when we're considering in the short term how we can be immediately strengthening the workforce, a question we can first ask is, how do we do more with the health and care workers that we already have? Thanks for all of you for continuing to contribute your inputs in the chat. 5 years, 6 years, 8 years, 2. What do we do today and tomorrow and within this year if we need to respond to health needs? There are sorts of discussions how we can do more with our existing health workforce at that service delivery level, at facilities and in communities, with site level or district level managers and stakeholders, and across both the public and the private sectors. So these kinds of questions would tend to be pretty context specific about performance and productivity, and they may have some locally created solutions. They would ideally be implemented and reviewed and improved upon within the short to medium term, focusing on accessibility, accountability, affordability, and reliability of the health services. So here, I'm going to push you all the way over to the blue section, the optimized section, to think about that existing workforce. Then, once we have made some attempts to, let's see, there we go. Once we've made attempts to optimize the existing workforce locally, we may consider we need more health and care workers, or we need to train them in a more systemic way. We need to review where they're deployed and where there are jobs, how many of those jobs there are. These are the sort of questions regarding workforce allocation that may happen at the level of the health system where there's authority for health workforce policies, planning, and financing. So this is where human resource management, support, monitoring, and policymaking come in, including things like if there are task sharing policies or policies around distributing them, how could that improve workforce effectiveness? So from short term to perhaps medium term, let's look at this green managed section of the life cycle. These interventions might require slightly longer, medium term or more systemic kinds of improvements and investments. And where health worker planning and policy making don't suffice to improve the current workforce, then we as health system actors and decision makers may need to go deeper to building. That may even mean rebuilding the workforce. And in that case, we really rely on the role of the education sector and pre-service training institutions, both public and private. And we need to understand what kinds of future health workers are being trained now, what kinds of skills they have, how many of them are expected. But as you say, we're looking at many years into the future. Efforts to build the health workforce are longer term, not only because of the necessary collaboration between health and education sectors, but also because training new graduates, perhaps in a new way, can take several years and many resources. And this is the orange build section of the life cycle. I'll also note that as we're looking at many development project cycles, which tend to be 5 years, perhaps 7 years at most, being able to measure the impact of an intervention in pre-service education is not particularly conducive to those typical project cycles. So I give you all of this context because our session is actually going to start with the short term. So we're going to look first at health worker strengthening approaches in the optimizing areas, and then in managing, and then finally in building. But before we do get into things, I just want to highlight the importance of being strategic and evidence-based. Indeed, data across the health worker life cycle is crucial for informing effective approaches. So if we're to consider any given country or district or community, planners and policymakers are always asking themselves, how many health workers do we have? What kinds? How good are their skills? Where are they? How many health workers are graduating in the coming years? Where are the jobs? How many health workers are leaving the workforce, whether by retiring or perishing or leaving the health sector? And of course, knowing how many and which ones and where and why are all really big and important questions. So an undercurrent of this whole session is the importance of data across the health worker cycle to inform investments, whether they're pre-service or in managing or optimizing. Complete, accurate, standardized, and up-to-date health workforce information is really important. And I'm illustrating here this Indonesia mapping where we're looking across the different stakeholders and data sources that exist within both public and private health labor markets that can be really helpful to consider these different flows. All right. We're going to come back and continue to revisit the life cycle, but I hope that that was helpful. Please do feel free to add any questions that you have into the chat. And I'm now going to pass it over to Jenny to set the scene for our first brainstorm activity. All right, so folks are coming back from the breakout rooms. that might have been a new approach, a little bit of a learning curve on either Jamboard or getting to the right place, but we'll have the opportunity to continue to improve upon those skills together throughout the rest of the session.
How do we get back to the regular room?
So here you are, you're in the regular room now.
Okay,
Glad you're here.
thank you.
Yes. So for those of you that were in the smaller groups, please feel free to share some takeaways. Were there any key stakeholders you were talking about, or any key barriers? Please share this, your inputs in the chat. I'll just, in the interest of time, summarize for those of us who stayed in the plenary to discuss this. Talked about the challenges of really integrating different stakeholders, that they're not always very well coordinated. Disciplinary silos and ego are challenges and contributors to not having very effective health workforce strengthening. We talked about the importance of transversal competencies as a solution, and that there's, again, this sort of lack of collaboration. Let's see, what do we have in the chat here? Thank you, Andresa. So she shares, from her understanding, the education system is a major standard stakeholder, and a major issue is the cost of education and perhaps the quality. So when we do think about those long-term investments in the health workforce, and that it really starts with pre-service education institutions, that there are really many opportunities. Thank you, Francesca. So thinking about the first question, key stakeholders include Ministry of Health, the training centers for lab technicians, Ministry for Higher Education, universities, which could be private and public, and that could be a range for, training a range of health worker cadres. And then those responsible for managing health workers includes public servants, the Ministry of Health or departments of health. And then in terms of optimizing, that includes civil society, absolutely. Communities and civil society have an important role to play. Thinking about the challenges, building challenges include having, it's highly competitive to enter training. When we think about the theme of CUGH and social justice, when we think about a lot of the inequities in even accessing health worker education, there are many challenges there. The quality of education, how expensive education is one of those barriers to access. Challenges to managing the workforce, not having a career path, not being motivated, having big salaries on the private side, but maybe less so on the level of care within communities, if I'm interpreting that right. And it really can vary depending on your specialization. Turnover is really high. Salary gaps. Thank you so much. I think that was all from, yes, Francesca. From Catherine Ann, with regards to stakeholders, that there were really a lot of overlapping roles between educational institutions, ministries of health, and healthcare institutions, as well as civil society, but also in terms of the kind of healthcare workforce and the care that they're advocating for. Excellent. All really insightful contributions. So keep these questions in mind, and keep your answers and reflections in mind as we do continue forward in our next section. So here, before we jump into the optimizing section and approaches and tools, what I want to just highlight is, here we go, let me get myself up to speed. Here, pulling up my notes, thank you. So now as we embark on tools and approaches to first optimize and then manage and build the health workforce, we highlight the range of areas for the education sector to be involved, many which could help address the challenges that you have highlighted. So, as promised, we're going to start with optimizing. On this premise that you first want to make the most of the health workforce that you have at the facility and community levels to achieve your health service delivery goals, it can help to achieve both technical and allocative efficiency, right? You're not going backwards, you're not investing in the very long term. There's some short-term as one says, low-hanging fruits that should be easy to harvest. So first, this is a quality improvement cycle approach to understanding health worker performance and productivity, which are needed for optimization. Consider first the kinds of health outcome or outcomes that you're trying to improve. So that might be a service delivery gap. It might be broader, like achieving primary health care coverage or UHC. But ideally, you have at that facility and community level a few more granular sorts of gaps and objectives you're trying to achieve, and information that exists at a disaggregated level, meaning at a site like a facility or hospital, health post, or even a community or catchment area. And you want to identify what sorts of health workforce problems may be contributing to that service delivery gap. And for simplicity, we generally consider these 4 categories: competency gaps, so do health workers have the right skills? Low staff engagement, are they motivated? Poor allocation of staff and tasks, where there are not enough of the right health workers doing the right things, or where there may be inefficient work processes. So thinking about how services are organized, or how clients and patients are flowing through the health facility. So for example, evidence has shown that clinicians in resource-poor settings often spend a large time at the clinic performing tasks that don't require specialized patient care skills. So that would be an example of inefficient processes. We also recognize that workforce problems could be a big combination of these categories. There may also be non-workforce related problems, such as infrastructure or water and sanitation or electricity or drugs or supplies, that also affect the service delivery. Many systemic problems are often people problems, so let's also just consider how recognizing the people problems can help to reach an effective solution. So then when we're moving to step 3, we want to dig deeper to understand the underlying or root causes of these problems. And step 4, then develop interventions to attempt to get at those underlying causes, and finally monitor those interventions in terms of their effectiveness in the process, and ideally whether or not it's actually improving the health outcome or service delivery gap as identified in step 1. So these kinds of cycles, they repeat as service data are monitored, the HRH situation can be reviewed, and the intervention can be improved to increase its effectiveness. We at HRH2030 did develop a toolkit to guide you through this process. It's not prescriptive and needs to be adapted to context and need, but it can be used at both facility and community levels. And you'll see in the Google Doc that we have shared, there is a list of all of the resources, so you'll be able to access those links that are in this presentation. I'll now pass it to Katie.
Great, thank you, Rachel. So as we think about how to ensure that health workers are engaged and motivated and supported, health emergencies like COVID-19 have shown that protecting health workers has to include PPE, but it has to go beyond that too. Health workers on the front line are exhausted and emotionally drained. And the World Health Organization has noted that frontline health workers are at risk of depression and anxiety. So protecting health workers has to include supporting their mental health. And we like to think about ways we can do that, for example, by ensuring the continuity of mental health services and by exploring new service delivery models to make that possible, like phone services or home visits, and making sure that these are accessible to health workers themselves. We can also try to address the mental health stigma that makes it hard for health workers to seek the care that they need. We can consider how to do this throughout the health worker life cycle, like incorporating mental health awareness and skills building in pre-service education, and ensuring that active health workers have access to transparent mental health services in their work and are supported by their employers to utilize those services. Next slide, please. So as an example of how we approach this on HRH2030, we collaborated with a university, the University of Malawi, and an app developer, Vitalk, to pilot an artificial intelligence virtual mental health care assistant to provide psychosocial well-being and resilient support to health workers in Malawi. The app included mental health checkups and friendly conversations with Vicky. You can see her here on the right, the virtual mental health assistant, and practical exercises to help health workers work through some questions that they may have about mental health. We also worked with the health workers' facilities to conduct workshops after the pilot of the app to further discuss mental health challenges among health workers and the participants' experiences with the app. The results of the pilot indicated lower rates of depression, anxiety, and burnout, as well as improved resilience. While this is just one potentially promising example, and we're still researching it, we wonder what successes or ideas you all have had in terms of supporting health workers' mental health and mental well-being. If you have anything you'd like to share, please feel free to do so in the chat as I hand over to Rachel to consider how health workers can be supported through supervision approaches.
Yeah, hello. I have a point that
Thank you. Please do share any comments that you may have in the chat, and we'll have opportunities in small groups to keep working through these things. So some of the built-in approaches for supporting health workers include supportive supervision. And that's an opportunity to also assess and act on health worker competency gaps, as well as perhaps with the right sorts of tools and supports, be able to support mental health of health workers. Routine supportive supervision, when done effectively, can greatly help to optimize workforce performance. HRH2030 conducted a systematic review that documented components, the inputs, processes, and effects or outcomes of health worker supervision around the world. And our research revealed some common themes. Health worker supervision most effectively enhances performance when it integrates evidence-based QI tools and processes, when it integrates digital supervision data into supervision processes, when it increases the use of health system information and performance data, when planning and prioritizing supervision visits, ideally to address the lowest performing facilities or the lowest performing service areas. And ideally, it's also sustained locally with contributions from the local level, because we have observed that there are often challenges to ensure adequate resourcing. Oh, and I see that, are you seeing the chat bordering onto our slides? There we go. So based on these key takeaways from our systematic review, HRH2030 collaborated with the Leyte Provincial Health Office in the Eastern Visayas of the Philippines, where they were interested to invest in their existing paper-based functional health worker supervision system to cover both public and private primary healthcare facilities. And it was a three-part investment: digitizing the existing supervision checklists, standardized ones, and deploying them on Android tablets, developing a dashboard for supervisors to review health worker supervision data, and also, third, providing those digital checklists to the health workers themselves so that they could assess themselves and report results to supervisors in between their quarterly supervision visits. So empowering them to a certain degree to understand their own results and then come into a supervision visit with that information at hand. And we conducted an experimental study across 10 interlocal health zones with interventions taking place in half of them. So we had a control. Preliminary results are still forthcoming, but so far we have identified that thanks to this intervention, health workers are better understanding of their own areas of low performance, because this app and the digital system provides access to data that typically only supervisors can access, and that overall performance data have been more easily shared and used by different health system actors. So now I'll pass it back to Katie to share examples about improving allocation of staff and tasks.
Thanks, Rachel. So this gets back to what we were talking about before in terms of it takes a long time to build new health workers. So what can we do with our existing health workers? So in this example, consider if poor allocation of staff or tasks was the workforce problem we identified, for example, using that toolkit Rachel mentioned. So the problem that we often see in the field is that we come across facilities that are short-staffed, where staff are overworked and waiting times for clients are long, and clients aren't really served in an optimal way as a result. So we have unmotivated staff who are feeling really tired and who may not be able to provide the highest quality care that they're capable of. And we have unsatisfied clients who might be at high risk of loss to follow-up. So one thing we can think about is how can we get from that situation to a situation where our clients are well served, where clients are happy, where providers are satisfied with their job, and where we have good treatment outcomes. The gut reaction is often that, well, we need more doctors and we need more nurses, and that might be true, but it often isn't the first solution we need to think of. Those extra doctors and nurses or other health workers might not be available, for example. So what we need to do is think through how we can use existing staff in a better way to provide client-centered care and promote retention while making the most of our available health workers. Next slide, please. So we developed the HRH optimization tools as our method of doing this with some of our partners. So these are Excel-based tools to help facility managers or district managers and planners review the existing health workforce, figure out ways to use health workers more efficiently, and better allocate human resources. So the tools take info that facilities usually already have, so these user inputs, things like service volumes, the number of staff you have available, and what tasks they're currently performing, so current task assignments. And the tool then provides estimates of staffing needs and gaps for the current scenario. It also has some interactivity that you can try out different things and see the HRH needs for different scenarios. For example, you can see what happens if you assign tasks to cadres differently, or if you try out a new service delivery model, you can see the effects of that on the workload of your health workers. So this allows you to use data to understand how short-staffed are you and what can you do to remedy that shortage by looking at optimization of your existing health workers before you look to investing in new health workers. The tool can also help analyze what model options might have the greatest impact to keep up with the growing client population. And it can also more generally contribute to universal health coverage. For example, by helping estimate how many health workers you need of certain types to deliver more services, or try a new service delivery model, or begin doing more community engagement. Next slide, please. So we've done variations of this tool application in a few different contexts. In Malawi, for example, in Indonesia, we did some HRH optimization for ART service delivery and HIV programs. And in Mali, for example, we have looked at some family planning and PHC services as well. So here's one example inspired by a health center in Mali that used the HOT4 family planning tool, and just kind of the thought process that we went through with them. So as we walk through this example, keep in mind, what's the current staffing available for family planning services? Are any staff overburdened? And are there any staff who maybe have extra time that, that could be allocated in a more efficient way? For example, just to start understanding this chart, if we look at doctors on the left, we see in gray that according to our current service delivery models and our current number of clients, we expect that we need one doctor in gray, and we have one doctor in blue. So that need is relatively balanced. For midwives, the next set of columns, the facility requires two, but only has one. So there's a small gap there that you can see in red. This gap is even more substantial in this facility among auxiliary midwives, who currently take on a majority of the family planning outreach tasks in the facility. The community health workers in the facility, on the other hand, seem to be a little underutilized, perhaps. We have 6 of them, but the current task allocation only requires 2. So perhaps to address the imbalances in this facility, since we know that there aren't auxiliary midwives out on the market looking for a job right now, we can instead look at some of the tasks that those midwives are performing and see if some of those could be shared with community health workers. So what we did with this Mali example is to help the facility think through how they can make that happen. For example, by determining a training plan to take on some of those tasks and working with the district to incorporate those tasks into the community health workers' job descriptions. So with this example in mind, we would love to hear from you as well about other ways that we can use HRH data to improve efficiency and what other steps are required to further optimize the health workforce. We're going to be thinking more about these questions in our next case study, so I'll hand over to Jenny.
All right, everyone, excuse me, welcome back. I hope that was a great breakout session and a good break as well, as we now dive into the next part of the health worker life cycle. We're going to be, just to reframe everyone, after first looking at the overall health worker life cycle and identifying then facility and community level efforts for optimizing the existing health workforce, we're now going to look at health workforce management functions, planning, support, monitoring, and policy making, where interventions for health workforce strengthening may be more structural, require additional time, effort, and resources to instate. So, for example, when health workers are employed, where are they going? How are they compensated? Over time, how are they retained in the healthcare sector? As a sub-question to this, how relevant are their skills? And importantly, who are the managers, leaders, and decision makers in the health system? What's the strength of their institutions and the skills they have to make well-informed decisions to ensure HRH policies and other policies are effectively implemented? And while effective leadership and governance are certainly cross-cutting areas, we'll discuss them for the purpose of this session in this section. So I'll pass it over now to Jenny.
Thank you so much, Rachel. And as Rachel mentioned, we've been through the first level of optimizing, and now we're talking about managing. So I would like to share an example of a tool that was used to measure and improve organizational maturity. The HRH2030 Capacity Building for Malaria project, which is a project that fell under our Comonics project for HRH2030, was specifically focused on strengthening leadership, management, and governance capacity of our malaria programs. So to do this, CBM embedded long-term technical advisors into national malaria control programs across 10 countries in West and Central Africa. So to achieve project objectives, technical advisors use the Capability Maturity Model, or CMM, which was adapted from Carnegie Mellon University to annually assess the institutional capacity of NMCPs to implement its function and to inform work planning. So this evaluation provided concrete, actionable information on the organization and what changes was necessary to improve performance and increase their maturity level. So across, in the image here, you can see on the slide, although the CMM uses a systemic approach, it was adapted for each NMCP context and was tailored to include domains relevant to NMCPs. So at the bottom of the slide here in blue, you'll see all the domains, including HRH and supply chain. So each of those domains contain multiple elements to measure performance. For example, in the HRH domain, assesses staff technical and management capacity and also staff retention. So the results from using the CMM tool were used to identify not only their progress in organizational maturity, but also to identify their strengths and challenges, again, especially in HRH. And those would become priority activities for improvement. For example, does the NMCP have practices for increasing its staff job satisfaction, motivation, retention? What is needed to strengthen their capacity, their technical capacity? And our team members updated on the most recent technical approaches, for example, in like clinical or even logistic management systems. And one of the other things that it measured were also, how do you retain staff at the district level where retention seems to be an issue? So the CMM was also used as a tool to guide the work planning, not just of their clinical activities, but to implement institutional capacity building activities to improve the health workforce at the institution level, but also at the individual level to manage your workforce properly. So in using this tool in this evaluation each year, one of the biggest lessons relevant to this conference was across all 10 projects in the countries was that although there are improvements year after year, HRH continues to be an issue, and strengthening HRH capacity needed to be decentralized. So it not only needed to be at the central office level, usually in most countries in a capital city, but in district offices and among health workers working at all levels. We do have the CMM model description and the tool available in one of the links through that Google Doc for you all to look at a later time. So I'll pass it over to Katie to talk a little bit more about strengthening organizational development and coordination.
Sure. So as Jenny's example touched on, in organizations, processes, relationships, and behaviors are all part of its ability to perform well and to help health workers perform well. But it's often hard to quantify these things. Adjust my earbuds. And it's hard to measure some of these traits as well. And we have to measure things in order to improve them. So for example, how can you measure how well an organization collaborates with others? In Colombia, as an example of how we think about organizational development for social workers, as well as the as part of our health and care worker definition, we worked with the Colombian Institute of Family Welfare to strengthen social services at the national, regional, and local levels. And ICBF has a lot of technical offices and a lot of administrative offices, and they have to be able to coordinate well together so that programs and strategies can be implemented seamlessly. For example, if there is a misunderstanding between the nutrition office and the logistics office, and maybe those offices have mismatched databases, so it's hard to retrieve information from each other, then that means that a food supplier in the system may not be able to access the address of a child's home and won't be able to deliver food on time before it's spoiled. So that poor coordination, that kind of loose concept at the organization level, had really tangible effects. The nutrition worker wasn't able to do their job correctly because they couldn't access the information, and the family receives less or doesn't receive the care that they're supposed to receive at all, or it's at poorer quality. So this poses a risk to ICBF's goals to provide equitable care and restore rights for children. So we had to ask at the national level, where was communication and coordination breaking down between ICBF technical offices? And to provide evidence for this, we implemented a relational coordination assessment, which was designed by Brandeis University, and I'll have linked in the resources as well for the session, to identify communication strengths and breakdowns within ICBF at the national level. So this enabled us to look at aspects like the ones that you see in this chart, like the frequency of communication, the timeliness of communication, and whether the different offices feel like they have shared goals and whether they respect each other and those kind of relationship things between different offices. So based on our baseline assessments, we were able to institute both individual and organizational improvements to try to move the coordination in a more positive direction. So at the individual level, we put in some leadership trainings, and we instituted new communication channels so that teams could share knowledge and get on the same page. And then at the organizational level, we addressed the more structural concerns behind those challenges. Like we made sure that their IT systems were actually interoperable across different divisions so that they can exchange data more easily. So all of these efforts improved the relational coordination from baseline to endline, as you can see here, which helps ICBF perform better services for its clients and make it easier for the social workers to actually perform their roles. There are other organizational development tools that we're going to link as well, but we wanted to share this example and I guess get the wheels turning. So as we interact with our partners or as we consider our own performance as organizations, these tools and thought processes can help us improve organizational processes to support health workers to do their best work. And with that, I'm going to hand back over to Rachel.
Thanks, Katie. So thinking about the challenges that you'd identified across stakeholders, the lack of coordination, some of the decision-making or leadership capacity, I think there are many opportunities for taking such tools to your own institutions. So now I'll share some examples of how to update skills of health workers through more formal training. So where there's a new policy, say task sharing or other, or a new sort of health goal, and there's a need to upskill current workers. In Timor-Leste, HRH2030 helped to ensure that there's high quality, standard, complete, and up-to-date information about in-service training. The challenge there in particular, health workers in Timor-Leste tend to complete their pre-service education at schools abroad, where there is an absence of medical schools, and many Pacific Islands face a similar challenge. They then receive in-service training that is much more context specific and continuing professional development within the country. The National Institutes of Health and other external partners, such as multilaterals, tend to lead those trainings. And the health worker training tracking system was paper-based, so it was really hard to coordinate and plan and monitor skills development of the existing workforce. And critical information about these health workers was fragmented. There was not a standard way of managing a data set or the names of the health worker by type. A lot of errors and poor quality. And so that made it really hard to have that full picture for informed evidence-based decisions about training needs and how to invest training resources. So HRH2030 with the National Institutes of Health designed a dynamic web-based training management information system, TMIS, that standardized the data. And we developed training modules so that managers would know how to support data entry and then strategic decision-making. As a result, Timor-Leste now has digitized training data for 5,000 public sector and 2,000 private sector health workers. And that data are available to empower those health system managers for how they're going to be investing in those resources. I'll give another example. In Jordan, we supported a framework development of a national system for improving health worker competencies. And the government of Jordan, health professional bodies, and other stakeholders drafted and proposed a relicensure bylaw for health workers based on earning CPD, continuing professional development credits, for each profession. And in April 2008, the bylaw was enacted by the government of Jordan, and this is the first of its kind in the country and was very much aligned with the national UHC goals. So thinking about a health worker-wide policy could be an opportunity to ensure that there are investments in CPD. Another example, in the Philippines, CPD, which is essential to quality care, was traditionally offered in person, and that, as you may know, takes health workers away from their posts, requires resources for training fees and travel costs, and covering facility tasks in the absence of those health workers, a number of other expenses. But as globally, e-learning is emerging as a best practice to maximize health workforce training investments, digital platforms mean health workers can learn from anywhere, and particularly where statistically, female health workers do participate less in CPD because of their non-work or caregiving responsibilities. This is an opportunity to equalize and to really allow access to more health workers. In 2020, also when travel restrictions were put in place with COVID, accessibility to online learning meant that health workers could continue to access new information and critical learning. And great to see that some of you did attend some of the trainings in the Philippines. So as of June 2021, the Department of Health Academy, the e-learning platform, offers 39 online courses, including a full module that was developed on COVID-19. And more than 18,000 health professionals have been able to benefit from the skills gained through e-learning. Of course, when it's reinforced by in-person supervision visits to identify performance gaps or no-do gaps and so forth, there are a lot more opportunities. All right, so I'm going to shift also to a challenge that had been highlighted in the brainstorm, looking at career pathways and advancement and retention. So first, understanding what the problem is or what the trends are. It's really important to use HRH data, ideally disaggregated, to understand trends. Gender discrimination, whether occupational or vertical segregation, can be really significant challenges in the health workforce. And I'll share some of the studies that HRH 2030 has done to review women's leadership in health. But it's relevant. The methodologies and the reports are available in the resources document. The approach could be really relevant for any underserved group within your country context that you would be trying to address. So the study showed in Madagascar and Senegal that some of the specific policies in country did increase female representation. They were gender equity driven policies. But the gains were really fragile, and more needs to be done to reach all levels of the system. In Jordan, we worked on a study to identify the barriers to leadership for women in Jordan, and it related to the need for equitable access to professional development opportunities, a need for enhanced mentoring and networking, an institutional commitment to gender equity, and flexibility in childcare support to help those leaders. I'll also note that the WHO's best practices for health worker retention when it comes to education and CPD is that really rural health workers are often underserved. And so when we think about either what e-learning or prioritizing rural health workers could really help to address access to health workers in the most underserved areas, address equity, but also be a win to that health worker who is providing more skills. And just to this question about career pathways and where I think we see a lot of opportunities for education institutions to bring their expertise. In many countries, there are not clear career pathways. There are not clear opportunities for stepwise advancement, and the investment in a health worker should be lifelong. There are emerging skills and needs that they may need to respond to, but that should also align with, jobs and grades. And so here are some illustrative career pathways that we had identified for consideration in different countries as HRH planners are trying to strategize about the ways that they would align those kinds of goals within their own system. So please do feel free to share ideas in the chat. Glad to see that this is seeming helpful. These pathways were developed as part of our HRH Principles and Practices course, and that link is also available in the resources. All right, we're racing along here. Back to you, Jenny, for our case study. Oops. Thank you. I was trying to navigate across this dashboard. All right. It looks like folks are coming back in from the breakout room, and it's great to see your comments and reflections to these case studies on the kinds of things that you might need to consider, particularly on the managing and in response to the case study problem that's set forth. Feel free to scroll across and look and learn and observe from others. Those Jamboards will be there. And as we move forward, we're now to the start of the health worker life cycle, building the future health workforce. We're going to discuss some of the approaches and tools, which may be a bit closer to home for many of you who are working in health professional education institutions. So as we highlighted earlier, and I think as you have also reflected in the Jamboards, Health planners want to know how many health workers we have, what kinds, how good are their skills, where are they, how many more health workers are graduating, where are the jobs. And to reinforce again, having complete, accurate, up-to-date health workforce information is really important for strategic use of these resources. And the WHO and other experts around the world have recommended some specific indicators to track and better inform HRH planning. And they call this compilation of indicators the National Health Workforce Accounts, sometimes used by their acronym NHWA. And countries report health worker data to a DHIS2 enabled digital portal. Stakeholders can access the aggregate and the disaggregated data. Country reporting is stepwise and progressive, and no given country has perfect or complete data, particularly as you're looking across these three sections, looking at the labor force, active health worker stock, and some of those different flows around spending within the health sector. Also understanding some of those population health needs, as we've touched on. And then, of course, across the vast array of health education institutions and how they're regulating and accrediting the different cadre types, right? Like schools for lab techs versus farm techs versus doctors and midwives, and how those kinds of finances are sustained and what kind of resources there are for those different programs. So I'll highlight here some of the particular data indicators that the education sector likely has or would hopefully have into the future, with the goal of having more complete and accurate health worker data. So that could be things like application rates, demographics of students, types of training programs, the number of graduates. Perhaps within your School of Public Health or School of Nursing, you know about your student body. But does the Minister of Education have a full picture, or the Ministry of Higher Education have a full picture? Does the ministry in charge of civil servants or of foreign affairs, if you have immigrating health workers, do they have that full picture? Does the Ministry of Health? Do local governments? So a lot of questions there. I'll also just highlight Module 3 focuses on indicators on the regulation and accreditation of health programs, including CPT, CPD, and IST. And then Module 4 does focus on financing of education, including how much the government is contributing to health workers' education. So there's a lot there. I think what would be most useful for you is to sort of sit with, okay, what are the kinds of data that we have? How are we sharing them, if at all? And what would be the kinds of incentives for more sharing and potentially more standardizing of that information? But now, shifting into that first step for building the future health workforce, we at HRH 2030 recognize the opportunity to bring more youth into the workforce. This is a win-win-win situation. If we have a global shortage of at least 18 million, let's get started, right? It's a win-win in that we can increase the number of health workers and strengthen the health system. We can help more communities achieve their health outcomes, and we can address youth unemployment. So lending from best practices in youth development writ large, HRH 2030 considered the positive youth development principles that could be integrated into health pre-service education to really meet youth needs. And that includes things like assets, agency, contribution, and enabling environment, which you'll see on the next slide. But before I get there, just want to also recognize the need for greater diversity in the health workforce itself. And coming back to these WHO best practices for health worker retention, there are many underrepresented groups in health, whether that's by language, ability, location, socioeconomic background, ethnicity, race, etc. And so where we want to invest in the long term, we really want to think about what are the ways, who do we want to be retaining now and into the future? And as you say, Sandra, yes, 1000% a need for greater diversity in faculty, which is sort of the very, very top of this pyramid of advancing in the health sector and in the education sector. So thinking about ways to ensure that curricula are reflecting rural health issues or other issues to address health equity, and locating health professional schools outside of major cities means that it's not just the cream of the crop who can afford health worker education that are perhaps not living those same experiences, perhaps those that have already experienced many privileges. How can we get those who are less privileged into the health sector, thriving and, and leading? So this framework that takes those positive youth development practices of contribution, so engaging youth and identifying their vocation for a career in health, ensuring their enabling environment, that they have both physical and psychological safety, that they are included, and that could mean the ways that curricula are taught, or the ways that if they're coming from an underserved background and they might need a little more help with some of the math and science-based coursework, that there are options for them, that they have a safety net so that they can continue to be engaged, and that they have a positive identity that is developed within their education. And that over time, they do continue to maintain those options, that they continue to have decent work. And as noted, that we need faculties with those skills to mentor underserved health professional students. We need to think about how practical curricula are and how much it's really serving those youth in their pre-service education experience. Coming back to one of those items that was identified early on, this need for comprehensive, integrated, patient-centered care. It cannot be achieved without interprofessional learning. I have observed these silos between schools of different health workers. Even if they don't train together, they may be performing the same or adjacent tasks or services. And when it comes to facility settings, they're working on the same teams. So how can there be interprofessional learning to promote interprofessional teams? How can we get there? We had identified, particularly looking across different kinds of schools, particularly technical, vocational, and education training institutions, or TVETs. They're not often in the conversation when it comes to health profession planning and discussions. Similarly, schools of public health tend to be very separated from some of the clinical and biomedical health models and discussions, as well as community health worker training institutions, which may be the Ministry of Health, but they may be some smaller private institutions. So yes, streamlining, as you say, James, to begin developing interest in the profession while they may be catching up and building some of the more foundational skills are really key. Thank you so much for your contributions here. I'll pass it over to Katie, who'll go a little deeper on an experience we had reviewing and updating an interprofessional competency.
Right, so particularly among this group of university experts, we have an opportunity to consider the competencies of health workers and how they set the foundation for the quality and equity of health providers' work. So as an example, on HRH2030, we explored how to define gender competencies for family planning providers. So as family planning providers overcome biases and as they offer quality, gender-sensitive, transformative services, they can help clients make voluntary and informed decisions about their family planning needs. And that can improve gender equality and improve reproductive health outcomes. So to help with this, we went through a thorough consultative process to define and test some competencies, including doing a desk review to develop a working definition of a gender competent family planning provider and start naming some specific domains and competencies. We then convened a group of experts to refine the competency definitions and revise the framework. We did a global virtual review to gather additional feedback from other experts, those who work in maybe curricular design of their own, as well as frontline workers from around the world. And then we field tested it in 2 country settings, in the Philippines and Ethiopia, to make sure that the competencies in the framework were, that they felt relevant to the health workers who might be using the competencies, or the competency framework. And this produced a gender competency framework and e-learning course. So the theory, oh, sorry, next slide, please. So the theory of the framework and kind of the backbone of the e-learning course that's taught revolves around the theory of change that suggests when family planning providers are competent at addressing gender issues, they can contribute to reproductive empowerment and gender equality. And the theory breaks this down into 6 domains, as you can see in this graphic. So things like using gender-sensitive communication and promoting an individual agency, and things like addressing gender-based violence. So these domains form the backbone of the competency framework, which then goes into a lot more detail on specific competencies. Next slide, please. So here's a quick look at one of the domains. So this one is the gender-sensitive communication domain. And you can see how it touches on several different competencies that a gender competent family planning provider would have. So things like knowledge, skills, and attitudes that the provider would be able to practice to provide gender competent family planning care. As we consider this example, and remember this is just part of that overall framework and just one of the 6 domains, we can think about how we can actually use these competencies. So for example, competencies could be used for pre-service education or in-service education to define the knowledge, skills, and attitudes that are required for service. They could maybe be used by regulatory bodies for accreditation and licensing purposes. And while these are just a couple ideas, we're wondering if you might have more. So if you would like to answer in the chat, we would like to know from your ideas about how can interprofessional competencies be used to reimagine how health provider curricula are designed. So can we rethink how we design our health worker training programs? And how can we ensure that competencies are practiced across different health workers? So not just those in specific training institutions, but every level of the healthcare system. With that, I'll hand back over to Rachel.
Thanks, Katie. So we had mentioned this previously, and you know, this has been a theme across the health worker life cycle writ large, the importance of diversifying the skill mix. And so a trend in global health and in many countries that don't have enough health workers in the right places with the right skills have been to professionalize community health workers. There are many countries where community health workers have been around for decades, if not centuries. They're, you know, doing work in communities, but are as of 2018, with the WHO's guidelines for optimizing community health worker programs, they have been additionally recognized as a crucial component of primary healthcare and UHC, with Astana and with each new investment that ministries of health and community health worker programs are making. But community health worker information, training, and planning are often very fragmented. And we want to highlight that there are opportunities and models for integrating community health worker data within broader health information systems. We worked in Liberia to develop a case study with some specific recommendations, you know, down into how you would be able to integrate community health workers into human resource information systems, share training data, share performance data within existing systems. But it's also been important, the need for data as decision makers, policy makers are determining if they will renew 5-year strategies and funding streams for community health workers. We also provided some support to do a return on investment study in Ethiopia, and with their health extension workers, per the methodology used and led by our consortium partner URC, we found a 9-to-1 return, which is really, you know, pretty incredible. And I think where there are in some countries, community health workers are being, you know, pinned up against other health workers, I think many opportunities to really think about interprofessional competencies, the ways that they can be providing patient-centered care and relieving the workload of many others. I'll just highlight here the WHO's 15 recommendations for optimizing the community health workforce. So if in your respective countries you are thinking about building out a new program or a new cadre, here you can see these recommendations are mapped on a life cycle approach. And there's great potential, particularly when it comes to determining what are those transversal competencies for a health worker in a given country or context. What are those career paths? What are the stepwise opportunities? And how can pre-service education institutions for higher learning really be places where people who are truly committed to the health and well-being of their communities, who are perhaps more representative of the population and those who are the most underserved, can really be growing. So there's lots more to discuss, but I'll pass it back over to Jenny now, where we'll have our final case study. Thanks.
Awesome. Thank you, Rachel.
All right, so it looks like folks are coming back into the plenary. Welcome back. Hope those were enjoyable conversations. So we'll give you just a minute. Hopefully you were able to hydrate, stretch as we approach this final half hour of the session. Glad that it was interesting. Wonderful. All right, so here we are. We have covered a lot of ground. We have covered a lot of different elements of the health workforce and a lot of people and a lot of data and a lot of tools. So we now want to dedicate this last half hour for the discussion and opportunities that, anything that you would like to share at this point. Any key reflections, any particular ideas? We had a few questions, which I have posted here. I'll put in the chat. As leaders, as thinkers, what are opportunities for partnerships? What are opportunities for collaboration? And I did post the questions in the chat, so I'm going to stop sharing and encourage anyone to turn on your video. I see, Mariam, you've got your hand raised, so I'll invite you to start.
Yeah, hello. There is an inclination in the system that we have to recruit more youth into our healthcare professional. But we have to address this very tactfully because IT is attracting them more, and this profession is, it needs a lot of efforts, a lot of time, and it's not paying well. So how we are encouraging them? On the contrary, we are driving them into other easy professions. So we have to do something with the payment and how to attract them. The same for the those who are about to retire or who are retired already from the health care professionals, to attract them back to the service as as a kind of backup for our service. And this epidemic proved that we are in a severe shortage of capabilities and of knowledge. So we have to utilize these people as well. Thank you.
Thank you for those reflections. Certainly those challenges, it's all about what can possibly be in your influence, both on the new and future workforce and those who are more experienced. I see Joanne, your hand is raised. Please share.
Yes, hello, everyone. I would just like to say that in my country, pandemic opened a lot of windows for healthcare system. By the way, I am from the Philippines, and as you all know, Filipino nurses are recognized in the world, but then in our own country, we are not. We're not given importance. We even have heard some high-ranking officials saying that it's what's the use of us studying for 4 years for getting a bachelor's degree in nursing? What I would like to say is that I think the pandemic in one way, because the people now understand how important nurses are and the healthcare is. And I hope that, a lot of sectors right now are starting to partner with us. The education sector is actually strengthening their forces, especially the College of Nursing and other healthcare sectors partnering with other ministries or other departments in order for us to combat the pandemic. We are geographically, my country is not geographically okay because we're islands and islets. We're an archipelago, so we need to help each other out in order for us to have a better healthcare system. And also, I would like to share that I think in training the future generation, we should still emphasize the importance of uh, this is a calling, not just a profession. And yes, it's true that we don't pay well, and that's why we need other sectors to help us in giving importance, in telling them that going abroad is just an option. We should we should treat the nurses well with dignity and pay them well, as you know they should pay as well, so that going abroad is just an option. It's not a necessity for us. So that's it.
Thank you for sharing,
Thank
Joanne.
you.
I'm seeing in the chat the challenges of attitudes towards nursing. It's not just limited to the Philippines, and would be happy to stay connected and share some resources. Whether it's data on nursing or some advocacy campaigns that are happening globally. Thank you, Marie. I see your hand raised.
Yeah. Hi, everyone. The comment that I have is like our tendency when we look at healthcare forces is often to look at competency, education, and one aspect that we may be not, looking into is everything that has to do with um, the working conditions, you know. So partnering with, like every like any department in economics or labor relationship would be some way to go, I believe, because we're more focusing into internal factors, than external factors. And I think the external factors contribute a lot for why we're not retaining healthcare professionals, or why um, certain professions have not gathered enough interest. So that's a comment I have, is to start looking at ways that we would be um, looking at what tools are used in labor relationship, for retaining the workers, or improving their work conditions so that they feel satisfied with their job, their profession, because we know that health profession is a devotion for some, it's a passion for some, but not for all. It also is a source of economic, and we need to look into that.
Thank you so much for sharing. All of what you say really resonates. Aisha's sharing in the chat. I think all healthcare workers should come together to improve the health of the populace. That's the ultimate goal, not interprofessional rivalry. And so when thinking about, we have had a lot of big ideas, thinking about circles of influence. What are the circles of influence that you have as professionals, as individuals? And how can we help to change the ways that, and the attitudes that maybe other decision makers have about the health workforce? I'm seeing Sandra chiming in that, in the US, the pandemic has changed the employer-employee relationship. Sandra, would you like to bring some of the perspectives from the US side? Feel free to come off of mute.
So in the US, the pandemic has shifted work to home, and that has, for many people who have the luxury of being able to work from home, changed the employer-employee relationship. So we talk about the great resignation. And the fact that employees now have a lot more say in what they will tolerate, and their supervisors need to really listen. There was a good program from Stanford talking about interaction between employees and their managers. And if the manager isn't listening, they're going to lose those employees. I think that's true of all disciplines, not just nursing. And so, once again, I have a very US perspective, but it probably works in other countries as well.
Thank you, Sandra. From what I have observed, I don't work clinically. I'm trained as a doula, but I'm not working regularly. This is my full-time work. Have seen a lot of statistics around this great resignation. I think the Washington Post had an article where they were surveying health workers and saying that about 3 in 10 intend to leave the health sector, and the pandemic has pushed them to their limits. We see a lot of these challenges of travel nurses, so those who are coming on a short-term contract, making a lot more money than those who are there and have been long retained within the system, and a lot of challenges there. Great, I see James, your hand is raised. Please do share your thoughts. Trying to, oh yeah, there we go.
Okay,
Yes,
can get
James.
me.
Yes, we get you well.
Okay, thank you so much. Actually, the point that I wanted to bring forward is the kind of education system that we begin nurturing our children right from childhood up to where they join institutions. Like in my country, you get where in the lower levels of education system, that is primary and coming to secondary, where the children are taught actually all the subjects. Someone is taught history, someone is taught geography, someone is taught fine art, someone is taught biology, chemistry, mathematics, a lot of things they are taught. And then it will reach an extent where this child actually has nowhere to take a direction in a career path. So to me, I could suggest giving career guidance for the children in their lower education levels as they are coming up with their education is a very key thing, because there a child will grow up with a vision of how I want to be in the future. And there we shall be able to come up with health workers who love their profession, but not health workers who end up being health workers by the force of maybe the parents or maybe the influence of friends who are health workers. So giving the children career guidance when they are still in their lower education system plays a key role in nurturing real professionals in the field of health. Thank you.
Thank you so much. I think you're highlighting maybe we need to go even further back in the health worker life cycle down to the primary school level. I have 3 school-aged kids, and thinking about the practical expertise they have in managing a pandemic or understanding things about their health in ways that I never expected. You know, what are ways that we can ensure that there are role models, that science and medical, sort of pre-medical education can be positive youth development sorts of things, so that we can bring more and more people to the health professions. Thanks so much. I'm seeing other comments. Thank you, Aisha. You know, thinking about how we could have trainings targeted more at the health team and not siloed into different cadres. I mean, how early on would we have to do that? I've seen some examples where within, you know, a broader university that has multiple health worker, you know, nursing, medical school, et cetera, everyone is taking their core classes together. So at least in their first year, nurses and doctors, future nurses and doctors know each other and they are working together. That could be a solution. Let's see, I'm just looking at, a lot of nurses are forced to endure unsatisfactory working conditions. Yes, Dr. Sylvia, I think, as you say, there's a gender component to this dynamic. I know in many countries, when you look at the health sector and the hierarchies, and you look at the education sector and the hierarchies, when you combine health education, you know, at this tertiary level, you see all of those hierarchies further steepen. You know, what are opportunities to break those down? You know, what are the opportunities for nurses to address those working conditions? Yes, James. Please feel free to unmute. I see, Sandra, your comment about providing mentorship. Love to hear. Feel free to chime in as well as James. I think you're working. There you go.
You can hear me now? Okay, thanks so much. Coming to the working condition of nurses, not only the nurses, actually all the health workers in the healthcare system, they deserve a very fair and good working conditions. You know, world is dynamic. Things keep coming, things keep going. Like this current COVID scenario has really taught the health system a big challenge. So keeping the nurses, the health workers in the system updated about the current scenarios in the world is the key thing, so that they have a positive mindset to things which are coming on their way, which used never to be there. So, you know, sometimes when you are hit by challenges, you begin to look for options. Options can be appreciation or complaints, you understand? So giving these people any updated information about what is currently happening is a very key thing, so that they have that mindset of being so expectant of a likeness of something which is going to come up on their way. That is the key thing. And the second one is giving these people continuous medical education, a medical education which might not have been part of their training in the schools. These are things which, like for the COVID case, when we were in school, no one taught us that when you are working, you need to be putting on a mask every time when you are with the person. But when COVID came, it was a must that you have to wear a mask if you love your life and if you love the life of the patient you are handling. So giving continuous medical education on matters which are on ground, not the ones which are history. Sometimes the books have history, but the ones on ground need that current information which they should be having in their brain to also, for them to also survive some of the scenarios which come so unexpectedly. You know how many health workers ended up losing their lives in the process of managing the COVID cases. So giving any information about what is on the ground helps them a lot. And that one is done through continuous medical education. And then the third one is, you know, when someone does a good work, needs an appreciation. If not necessarily money, but saying someone, you have done a great job, plays a big role, and the person will feel has been honored. You know how the nurses were wired up with the work during COVID time, they were tired, exhausted, there was no time for resting, and some of them actually ended up losing their lives just because of the workload on them, which has never been there. So appreciating what someone has sacrificed life to do is a very key thing, which I think needed to be done for the healthcare professionals, even though things are not working well, but they deserve to be appreciated, if not by material things, but gathering them and passing to them and information, showing them how much they have been appreciated for the work done is a very key thing in healthcare systems. Thanks.
Absolutely. Thank you, James. I think recognition can certainly go a long way, but we also want to recognize the importance of the foundation of decent work, of course. I really appreciate those points. Just seeing in the comments as well, interprofessional awareness and education being the way forward. Ignorance about the capabilities and training of other cadres or disciplines must be addressed early in the education process. And I couldn't agree more. Thank you, Dr. Sylvia. Jenny, I wanted to pass it to you to see if there were any takeaways that you had, anything you wanted to bring from what you have experienced today.
Yeah, thank you so much, Rachel. And thank you everybody for joining in, for really great participation through the gem boards. And as we're learning as we go along. So I really appreciated the participation, everyone's comments in the chat. I think the biggest takeaway for just looking at the gem boards and people's comments here in the chat of this idea of continuing education and just skills training, not just when you were in school or you just starting out in whatever level of health professional you are, but to continue that. I think COVID definitely highlighted a lot of issues and inequities with training and who at the end is underground. Not just in the US, but in a lot of the countries that HRH has worked in and Commonix General as an organization is working in. Diversity and not just the people that we work with and recognition of our nurses, health workers, but also equitable pay for all of them, and I can use Commonix as an example where we're a company that works in supply chain and we do HRH work. A lot of times people working at the last mile are community health workers and they're not professionalized, you know what I mean? So they don't really get the benefits that a nurse or a doctor or someone who's at the top as a director of a project is getting. So I think really the lessons learned here for me in this conversation is really we need to professionalize health workers, but we also need to have that continuing education at all levels and continue to optimize who we have currently, but also how do we build from the very beginning. So this has been such a great conversation. I want to thank everybody for your feedback and contributions.
Thanks. And before I pass it to Katie, I saw, Sandra, that your hand was raised. Feel free to share.
I was just going to go back to the issue of mentorship that can occur at really all levels. For example, in the free clinic where I volunteer, we mentor, I'm a nurse practitioner, I mentor pre-med and med students, I mentor nursing students. That can happen with faculty in a university setting. It can happen with senior staff or preceptors at the practice level, particularly with new graduates who go through a pretty rough transition from student to practicing nurse. As I said, it can take up to 3 years for them to feel like they can fly solo. I have a son who's a registered nurse, and so I went through that with him also.
Oh, thank you for sharing. Yes, I think mentorship, we could really go deep on that as well, the value that it has in ensuring quality, ensuring that one is responding to one's vocation. Your son is very lucky to have a mentor in his mom as well. Before I pass it to Katie, I see Mariam, you have your hand raised.
Yeah, I suggest to have a kind of international licensing, recognition of the education of healthcare professionals, other than when they go from a country to a country, their capabilities, their knowledge is wasted. Trying to get a new license and prove that they were having a global education and, these limits, these barriers against the health profession.
Absolutely. And you may be familiar with the European Union model where, within the Schengen area that there is a uniform sort of opportunity so that the labor market is open, but that's not the case in many contexts. So that's challenging. All right, I'll pass it to Katie.
Thanks, Rachel. So I'll try not to take too long in case there are any other comments from the group, but I think that one of the big takeaways that I'll be taking from the session is all of the comments and discussion points that folks have offered about interprofessional collaboration, interprofessional learning.
I'm not so sure.
Maybe we can go to James. I think that that's a challenge that we see in terms of different cadres and how to support different cadres as they collaborate together on health workforce teams. But it's also something we see in Chemonics in our view of like international development and how I know we've talked about silos for years and years, but it's the divisions between different kinds of health workers are mirrored in the different disease programs. Like we have HIV separate from FP, even though, like, for example, one of our case studies was, both of our programs, family planning and HIV, are facing the same issue of youth engagement. So I think that there are opportunities to bring that interprofessional spirit in development programs and our health worker teams, and that's something that I'll be taking forward from this. And I'm very excited that some of the education experts on this call are engaged in that as well.
Agreed. Thanks so much, Katie. That was really nicely said. I see, Dr. Sylvia, you were commenting about how curricula should be part of the change. I'd love to hear more, see what you might have to share with participants if you're able to come off mute and share your thoughts.
Yes, I just wanted to add that part of the interprofessional progress or appreciation really depends on the training all disciplines receive. And if they begin to work and study certain parts of their program together, I believe the appreciation of the contribution of each discipline would be a lot better than it is. And, the pharmacists, understanding what they do, we think we understand, but we really don't have a good working knowledge of the depth of their exposure, and the team effort in healthcare would be strengthened, and all levels will get the appreciation they deserve if the curriculum is designed to promote that working relationship from the very beginning.
Very nicely stated. To perhaps probe a little further, I mean, what are the current barriers to this? I know there are many structures in a lot of settings for revising curricula and trying to get everyone to agree, okay, let's try to revise our curricula together. I mean, how would we go about it? What would be the challenges? I see your hand, Sandra.
It's really difficult. Our university is currently implementing the American Association of Colleges of Nursing Essentials essential competencies across all levels of nursing. When our pre-nursing students go to anatomy and physiology and some of those science-based courses, it's almost like the course is dumbed down because they're nurses, so they're not, and I shouldn't have said that, that's probably wrong, but it's like, it's not the same course for someone going into nursing as it is for a pre-med student, for example. So trying to get them into those same classes in the beginning probably is better to some of the social sciences type things. We do have an interprofessional opportunity with the medical school and the nursing school later on when they do a case study together. But that's kind of just a one-off. They're not doing, like I taught pharmacology for years. I had some pre-pharmacy students, some pre-med students in there. But again, oftentimes there was a disconnect. So it's really difficult because changing curricula can be very, very time consuming. And there's a lot of pushback for faculty who are exhausted. Faculty are exhausted too.
Great points. So as we're looking down to the root of, how we could get there, that is a big challenge, certainly. Dr. Sylvia, I see your hand raised.
I really believe that the preclinical years, they're crucial in terms of value building and developing that collegial attitude. Yes, some people may perceive it's more to do with the social sciences and humanities, but early, and I think where there's a will, there's a way. Before medical students really know anything about the intricacies of anatomy and physiology and pharmacology, attitudes are being formed, and these also impact how they deliver care in the community. Because the doctor is not, let's say, at the head of the totem pole and everyone else falls in below. When we are talking about patient-centered care, there is a role for every discipline. And the sooner we get students and we orient them, the better the product will be at the end. That's all I wanted to share, because I've seen it on the ground. I've worked in Rwanda and Uganda.
Thank you so much, Dr. Sylvia. That was very eloquently stated. I think that was very motivating to many of us listening. And, there's the adage, the best time to plant a tree of change was 10 years ago, but the second best time is today, right? So I hope that there are ways and opportunities that you can identify for promoting patient-centered care, for thinking about the role of health professional organizations as opportunities to truly transform the current and the future health workforce. We're coming up on time. We have had a beautiful journey together, but there are other things to do today. So what I would really like to do is truly thank you all for your wonderful, meaningful contributions. Here I'm just posting an acknowledgement to the many contributors to some of the tools and approaches that we have touched on today, some of our HRH 2030 staff and partners, but really first and foremost, the ministries of health and government, university, civil society, and community partners, and of course the health workers who have all contributed to furthering the thinking and acting on ways that we can build, manage, and optimize the health workforce. So we will be sharing the resources will be, you have that Google Doc. We will put in a link to the presentation that we have shared with you today. We encourage you to take a look at the resources. We'll include our email addresses there. I realize we don't have those. I can pop mine in the chat as well. And then just want to conclude with a wholehearted thank you to all of you for your great contributions today. I hope you have a wonderful rest of your experience with CUGH, and I hope that you can carry ideas and opportunities with you. Thank you so much. Thanks to Katie and Jenny for their great work. Thanks to you all.
Thank you, everyone.